Okay, good morning, everyone. My name is Adam Kafal. I'm one of the neurosurgery residents here at PGY2. And today I'm going to be talking about spinal vascular malformations. And as some of you might know, I already finished my 4 month of rotation on the spine service, which kind of improvised me to do this project and go on this project based on what I'm going to describe next on why I started this presentation. So I have no disclosures. So the outline today for our presentation, I'm going to talk about an institutional case that we had. I'm going to talk about the anatomy of the spinal cord and the vascular spine anatomy. We're going to go through like a historical perspective in 3 different medical eras, and then the evolving classification of the spinal vascular malformations. And lastly, I'm going to give some reflection and conclusion on that. So first, the institutional case. So on our service, there was a 73-year-old male who was referred to UMH clinic with 6-month history of progressive leg weakness, decreased sensation in his bilateral lower extremities. It all started in January 22 when he was at work and then had a sudden loss of strength and his legs gave out on him. So soon he started having bilateral, a decrease in strength in his extremities, as well as cramping in his buttocks and legs, and started using a walker and even a wheelchair to ambulate. He also started having some numbness in his lower extremities. Moving on, in February, he started having some bladder incontinence, which he described as some spotting, as well as loss of his sphincter control. On examining the patient had a mild weakness in his on a motor exam in terms of his extensors in the right lower extremity and left lower extremity. He has decreased sensory and bilateral lower extremities in terms of light touch, vibration, and pinprick and proprioception. So patient got multiple imaging. So we'll start first with his MRI of the lumbar spine. So you can see here, this patient has a lumbar stenosis extending from L2 to L5 with a grade 1 spondylolisthesis at L4, L5. Patient also has a history of a laminectomy and a lumbar L4, L5 for a synovial cyst resection. Seems like a very classical case, but as we go on, patient also had an MRI of his thoracic spine, which is more interesting given that the patient had a thoracic 8 to T10, T2 flow voids, as well as swelling of his cord and evidence of cord signal change, all which lead to a diagnosis of a questionable spinal dural AV fistula, which we're going to learn more about as we go on. So to sum this up, the patient has 2 distinct pathologies. Patient has thoracic myelopathy with spinal cord signal change and a suspected dural AV fistula, for which we are recommending to get a dedicated spinal angiogram, potential embolization, followed by a thoracic laminectomy for the intradural exploration clipping of this fistula. It also has the lumbar stenosis with a neurogenic claudication, which we would recommend a lumbar 2 to 5 LAMI with in situ fusion at L4, L5. The case becomes more interesting because this patient goes to the angio suite and then he gets, they do the angio, but there's no AV fistula to be seen on the angiogram. So they decide afterwards that they're going to do aortograms to evaluate if there's a segmental level that they might have missed. So they do that. They do the thoracic aortogram, thoracolumbar, followed by the lumbar aorta and the iliac coronals. Still, the AV fistula is not seen. So at this point, they decide, okay, let's re-image again the thoracic 7 to T11, given that the MRI is showing T8 to T10. But still, afterwards, on the thoracic and the lumbar arteriovenous fistula is still not noted on the 22 vessel and the 3 vessel diagnostic angiogram. So a patient was decided that we're going to get an MRA overnight. So patient got out of the angio suite, went to the MRA, because now the question is maybe the patient has a thrombosed dural AV fistula. And then the MRA was done in the evening, and then it still showed that fistula's connection on the right T8, T9 that appeared to be connected to his dural venous plexus. So now the plan, okay, so we have a negative angio, but we still have an MRA that shows the fistula. So we decided to take the patient to the OR the next morning. And in the OR, T6 to T9 laminectomy was done. Once the dura was incised, the obvious large, massive dorsal veins were seen. And then you can see the fistula's connection between an artery within the dura and the mass of veins. So they bipolar and cut this fistula, and then a dramatic change is seen in the venous anatomy with significant reduction of the red coloration of the dorsal veins. All this we're going to explain later about the pathophysiology, what's happening here. But just to let you know, so we see fistula is seen, fistula is bipolar, and the patient is doing well. Surgery went uneventful. 2 weeks follow-up. So prior to the surgery, patient had difficulty in ambulating, leg weakness, leg numbness, and degree of renal incontinence. Post-operatively, he's doing well. His back pain has improved. He's stating now that his walking and the gait imbalance slightly improved. He still continues to have urinary incontinence. Moving up to 2-month follow-up, which is like 3 or 4 days ago, the patient has been able to ambulate much better. Now he's walking without assistance. So walking now instead of a walker in a wheelchair, he's walking without assistance. The patient wants to return to work, asking for a return to work letter. So the patient is doing really good. Now we plan, okay, let's see the patient in 4 to 6 months with a repeat MRI of the thoracic and lumbar spine, because the patient, as you recall, also had the lumbar pathology. So this is the case that I'm going to be reflecting on as I go through my presentation. So next I'm going to talk about the anatomy. So it's very essential to understand the spinal cord vascular anatomy to be able to understand the spinal vascular malformations, which is something that has developed over time. So I want to highlight the things that we know about the arterial anatomy of the spinal cord as of now. The spinal cord has 2 arterial networks, the anterior network and the posterior network. The anterior network is derived from the anterior spinal artery, as we all know, that is coming from the vertebral arteries. And then we have the posterior, which is a plexiform of collaterals of 2 posterior lateral arteries. Both those systems are augmented by medullary arteries, which we as know during the gestation and during the patient, as the person develops, those become rudimentary, but only 6 to 10 remain. So those medullary arteries in the cervical region are coming from the vertebral arteries and thyrocervical trunk, while the ones in the thoracic and lumbar region are coming from the segmental vessels of the aorta and the iliac arteries. We have a dominant cervical medullary artery, which is known as the artery of Lazarus, which usually comes between C5 to C7, and the largest dominant artery, which I'm sure everyone knows about, the artery of Adamkevich. This is what Adamkevich put in his initial paper or initial description, where he describes about how the anterior spinal artery comes and gets augmented, which what he describes as his, which is now known as the artery of Adamkevich. And this is here another paper also which describes it. And as you see here, they highlight that this vessel is around like T8. So there's a variation of where the patients, people would have this artery, which is going between T8 to L2. Some say also it can go up to T4. So moving on to what we know now about the modern spinal vascular anatomy. We spoke about this, how kind of gets augmented by the medullary arteries, and which is very important to understand the importance of the artery of Adamkevich, given that if this artery is taken out, whether it's an endo surgery, then you would have like an infarction in your cord. And as you see here under angio, the artery is known by its hairpin looking and how it joins the anterior spinal artery. The highlights of the venous anatomy. So like the arterial system, it's also composed of 2 radially arranged vascular networks. Sulcal vein is in the anterior.
Hey, Adam, can I interrupt you just for 1 second? Because those 2 pictures, if you can go back to the 2 pictures of the arterial anatomy, the Netter pictures. Yeah, I just think it's important for people to realize that, and it comes up all the time. We're just doing the oral board review, and people always ask, like, if I'm doing a lateral approach for a corpectomy and I have to take the segmental vessel at the level of the artery of Adamkevich, is that a problem? And the answer is no. And the reason is, if you go back to the next slide before it, one more in advance, no. There, yeah, if you look at that picture, you can see that if you take the segmental right off the aorta and clip it, you'll get flow through the intercostal branch that will still fill the radiculomedullary vessel. So there's no need to do like a pre-op angiogram to figure out which is the branch for the artery Vidamkowitz, because you'll always get good flow if you take that segmental off the lateral vertebral body.
Oh,
Go ahead, sorry.
that's a very interesting, that's a very good learning point for me myself. Thank you, Dr. Levy. So going back to, I think we were talking about the venous anatomy. So as I mentioned, it's very similar to the arterial system, but also now we're talking about how the spinal cord drains to the coronal venous plexus, which is something that's going to be very important for our understanding of those vascular malformations. And the medullary veins, as well as the medullary arteries, are not present in each segmental level. So that's something we need to also understand. And they are sporadically along the long axis of the spinal cord. So here is another picture from Dr. Oldfield's publications, where it shows the anterior spinal artery joined by the medullary arteries. And then you can see here, this is very important, understanding where the dural artery comes from and the coronal venous plexus, which is going to be very important for our understanding next when we start talking about dural AV fistulas. So next, I'm going to talk about the historical perspective and the different eras when it came to vascular malformations and how was it seen. So it would like to define them in 3 different eras. The first era was the early observations, and then the Middle Ages, and then the modern era. And each era is defined by specific findings. So early observations, on the left here, you see this is Virchow, where he kind of provided the earliest classification of spinal vascular lesions, but he kind of described them as neoplasms, not as vascular malformations, which is going to be a differentiating point when we come to further classifications, where we talk about differentiating neoplasms from hemangioblastoma, why is it, and vascular malformations, AVMs and AV fistulas, and so on, and cavernomas. On the right here, this is Krauss. He was the first physician to recognize a spinal lesion during a laminectomy, but he did not resect that lesion, because in the history, when we start talking about the first person that took out a vascular malformation, it would be Charles Ellsberg. So he attempted to excise this spinal vascular malformation in a documented case for a 13-year-old that presented to NYU with a 1-year history of bilateral thigh pain. And this kid had spastic periparesis with loss of bladder and bowel control. And Ellsberg describes in his writings about the surgery and what he noted. So as you can see here, this is the picture or illustration with this case. He describes the vessels as tortuous and about 4 centimeters in length, 1 centimeter in thickness, which we would eventually find out this should have been described as a juvenile AVM more than anything. The surgery, they tried this surgery to take out the vessels, but there was no improvement in the patient. And as we're going to describe later, because that should have not been the surgical procedure done at that time. So the modern era, 1960s up till now. So a lot of things have happened, which led to where we are today. So understanding how interventional neuroradiology has emerged and how it has been developing over time, the introduction of operating microscopes, the microsurgical instruments, progression in anesthesiology, all led to where we are today. So this era is highlighted by the connection of the Americans, the English, and the French. So major contributions and highlights have emerged due to this collaboration. So we're starting first in England, where Log here worked with the neurologist Brian Kendall in London, and they have started understanding the pathophysiological mechanisms behind the vascular malformations. So now it's understood that they start understanding it's about the venous hypertension. It's not about what is thought about the vascular pattern, because people, and in Ellsberg's case, they would take out the whole vascular lesion and not understanding that it's due to the venous hypertension rather than the malformation itself. And then what they thought to be as venous angiomas actually turned out to be our dural AV fistulas. And we're going to explain more what we mean by that as we go on. At the same time in French, the neuroradiologist Jinjian in Paris was making also major contributions to understanding selective angiography and embolization. Coming to the US, so the key center during that early times was in NIH, where we see here on the left is Dr. Dokman, and which he was the leader of the group, as along with Dr. DiChiaro and Professor Oldfield as well. And here we see Dr. also Omaya holding his famous Omaya reservoir. All their contributions had led to the following classification that we initially started using, which is the type 1, type 2, type 3, type 4. So type 1, which was explained as the dural AV fistula, which was also known as type 1 spinal AVMs, the type 2, which is glomus AVMs, type 3 juvenile AVMs, and the type 4, which was described and first recognized by our professor, Dr. Harros, in his case report in Journal of Neurosurgery, where he added this new explanation of direct spinal AV fistulas, which was not included. I'm gonna go through each classification in detail to understand how they differ, how we've developed, and how we've evolved. So as I spoke, so Virchow started talking about the angioma cavernosum. So he started noticing this absence of parenchyma between the blood vessels, which could have been at that time the cavernomas, which he's trying to explain, and then the angioma racemosum, which is explained by him as some sort of telangiectasias, and also angioma racemosum arterialis venosum, which could be also mainly the vascular malformations or the fistulas, which we're going to talk about. Moving on, as I mentioned, Ellsberg, by doing the first cases, he started also giving his classification where he described the vascular malformations, either an aneurysm of the spinal vessels, either it's an angioma in which a mass of dilated veins penetrates the spinal cord, and then he described what is called hemorrhoids of the spinal pia mater, or dilatation of the posterior spinal veins, which could be many different things, whether it's a dural AV fistula, whether it's an AVM. It was not very clear at that time for him. Cushing and Bailey came back next, and now they started differentiating between the tumors and the vascular malformations. So they started describing the hemangioblastomas and started also describing the vascular malformations. And they divide them into either it's a plexus of dilated veins for them, or it's aneurysmal varix, venous angiomas, telangiectasias, or maybe a combination of both, which we're going to know later on. An AVM could also develop aneurysms. Wyburn Mason, so he also started developing his own classification, which differed than the one from Cushing and Bailey, by understanding a little bit more about the venous abnormalities versus the arteriovenous and arterial anomalies, and defining what are the telangiectasias, which were called back then a cavernoma or cavernous angiomas. And also it started talking about the different tumors, hemangioblastomas, hemangioendotheliomas, and lymphangioma. Moving forward to the American English-French connection, which I spoke about briefly. Now we have the type 1 dural AV fistula, the glomus AVMs, juvenile AVMs, and the direct spinal AVF. So what do we mean by each of those types? So first, the dural arteriovenous fistula, which is the type 1. So as you can see here, the fistula is developed at the entrance of the nerve root between the you can see here the medullary vein and the coronal venous plexus and the dural artery. So you can see here the feeding dural artery develop causing with the fistula, and then which leads eventually to the venous stagnation. And that's what we call the dural AV fistulas. And that's what's also referred to type 1 AVMs, which is the most common types of AV fistulas. And as you can see here, Dr. Oldfield highlights the surgical treatment is you just need to find the fistula's point and bipolar or ligate or clip the fistula. And this is when you see the dramatic change in how this venous hypertension or venous congestion and the what's also known as arterialization of the veins disappear, and then the veins would change their colors dramatically. Moving on to the next type of vascular malformations, which is the glomus AVMs. So glomus AVMs are also given multiple different names. So you can see here, there's a compact of vessels, and those vessels, as you can see here, they're intramedullary at this point. They're no longer dural. They're actually in the spine, in the cord itself. And this, to differentiate it between the juvenile, you can see here the juvenile, it's a more diffuse than the glomus, where you can see here it's very compact. And the glomus AVMs are thought to be more in adults versus the juvenile AVMs, which are more in the younger people, which is also explained in Ellsberg case, which we just talked about. It most likely have been a juvenile AVM in this 13-year-old kid. And you can see here as well the angio showing this diffuse nidus across the whole part. And the last type, which is type 4, which is a direct spinal AV fistulas, which now also has many other names, including the perimedullary AVFs or the intradural arteriovenous fistula. And this is a direct connection that comes between the anterior spinal artery and the coronal venous plexus. So at this point, you're inside the dura. And also, you can see here Dr. Oldfield showing the surgical method is just try to find the fistula's point, try to take it out. The one thing that we will highlight later is that it might not be only one fistula's point. Okay, and this is actually the angio from the case that Dr. Harris presented at JNS, and that they started labeling the type 4 direct spinal AV fistulas. Moving on to, in 2002, Spetzler, Whitler, Rena, and Porter started coming up with a new broader category for understanding vascular malformations and vascular lesions. So they define them according to the neoplastic vascular lesions, which we talk about, the hemangioblastomas and the cavernous malformations, spinal aneurysm, which are very, very rare. And then they started defining or labeling or classifying the AVs, AV fistulas and AVMs separately. Because as you've noticed earlier, I talked about type 1, which was a dural AV fistula, type 2 was actually AVM, type 3 was an AVM, and then type 4 was a direct AV fistula. So the classification that Spetzler and colleagues are proposing is here, and as you can see, in comparison with other classifications. So I want you to look at the upper level of the classification, where we're going to talk about each of them in detail, but they talk about the dorsal intradural, which would be the type 1 in the De Chiaro and Harris classification, the ventral intradural, which would be the type 4 or the perimedullary or the direct AV fistula, and the extradural, which is a new category that they brought in that was not classified in the prior classification I just presented. And then they also, for the AVM, they discussed the intramedullary, which would be the glomus tumors, and then the extradural, intradural, which would be the juvenile. And then they added another category, which was not described as well, is the conus AVMs. So going through each, and those are the actual pictures from their presentation and how they explain each type of them. So as I discussed briefly, so this is the intradural dorsal arteriovenous fistula, which is also known as type 1, which is also known as the dural spinal AV fistula. And as you can see here, the nerve root, you can see the artery, you can see the arterialization of the vein, which they kind of show here. You see how it changes color, you see the engorgement of the vessels. You try to, it makes it more understandable of how this engorgement is leading to and arterialization of the vein is leading to the venous hypertension. And as you can see here on the MRIs, intraoperatively with the dye, the next one, we talked about the dorsal intradural. The next one is going to be the intradural ventral AV fistulas. This is what is known as type 4. This is what Dr. Harris explained in his JNS paper. And this is the direct intradural, where it's where you can see here, the connection now is between the anterior spinal artery and the coronal venous plexus. And you can see also the arterialization. Moving to the last part is the extradural arteriovenous fistulas. And those fistulas were not explained as much in the classification by DeCaro and Harrows, but this is basically the fistula is outside of the dura. The compression is actually happening more on the nerve roots outside of the cord. Moving on to AVMs now. So AVMs, they also talk about the intramedullary AVMs, which we have known as two different types. So the compact type, which we describe as the glomus, which is also known as type 2, and then the diffuse, which is known as the juvenile or type 3. Then the last part, the other part, sorry, that we did not talk about is the extradural, intradural AVMs. This is a rare type of AVMs, which is also known as a Cobb syndrome, where you have an AVM that extends all through the bone, through the skin, through everywhere. So this is a very special also type of AVMs that they added to their classification. And then the last thing is the conus medullaris AVMs, which is more specified to be found in the conus medullaris lesion. And they, based on their experience, they have noted many cases where they thought that it should be a classification by itself, given the location and given that the patient presents with radiculopathy and myelopathy at the same time. So that's why the conus medullaris is added to their proposed classification. So here once more is the proposed classification, and I'm highlighting how you can compare and understand it with the DeCaro and Harrows classification and the additions they've added, and how they thought that this proposed classification helps more in understanding, and it makes it easier to differentiate between an AV fistula and AVM without combining them in one classification, to help in their moving on next with understanding the different therapies and treatments and how we're going to define which patients are more liable to benefit more from surgery versus patients that would benefit more from embolization. I think that's a very good addition to even from research perspective to be able to find outcomes when you combine different pathologies together. Lastly, I'm going to do some reflection and conclusion on what I've been talking about in terms of the case that I described early on and what we witnessed in the case, and then what would be the moving steps moving forward, and what I learned from my case at the Jackson Memorial during my 4-month rotation. So looking back into the literature, I found the case that Dr. Harrows mentioned in his email to us as residents and explaining this patient that he spoke about, the patient who never forgot, which is a very interesting case. And reflecting on our case, I think there's a lot of similarities to be taken from. So for you that would not know about this case, it's a case where a patient actually had a laminectomy and developed new onset of bilateral lower extremity weakness after the surgeries. And then after they went for revision surgery, and now the patient became paraplegic, and then they had to transfer the patient to Dr. Harrows. And when he suspected a spinal dural AV fistula, also the angio did not show a fistula, but they decided based on their understanding of the patient's history and diagnosis and clinical signs to take the patient to the OR, do a T12 to L1 laminectomy, where they also found that there is a dural AV fistula, and then the patient improved drastically. So that's very similar to what we did, although the angio did not show anything. In their case, the MRI did not show anything, but in our case, we had the MRA to kind of also help us with understanding. So I went into the literature more to understand, okay, is it common not to see the AV fistulas on the angio? So I found also this paper by Dr. Oldfield and Dr. Dokeman, where they kind of explain how to manage spinal dural AV fistulas that are undetected by arteriography, which is very similar to what we ran into and very similar to what we did. But they also went through different hypotheses of why don't we see the dural AV fistulas. which helped me understand and maybe hypothesize maybe why we did not see it in our case. So they explained how severe atherosclerosis might be with advanced age, might include the lumen of the segmental arteries, which might be why we did not see it. Looking back, our patient was 73 years old. It might be a good explanation. They also explained for like future reference and for our educations is that 10 to 15% of patients with fistulas actually do not get their blood supply from the aortic segmental arteries, and that's why they might be missed on the routine spinal arteriography. And that when we do the arteriography, that we need to do the vertebral and the carotid arteries to detect any AVFs in the posterior fossa draining into the spinal venous system, as well as any AV fistulas from the sacral plexus as well. Looking into the literature, the team here and my colleagues have done a lot of work trying to understand how to manage spinal AV fistulas, understanding the challenges in diagnosing and managing AV fistula, especially the ones that have been taken into angio and they were already embolized. Looking into also during the angio, how to understand the different angiographies using the 3Ds, and then also understanding the importance of MRA angiography and the different management and surgical procedures that we can do to treat those spinal AV fistulas. So in my readings, the things that I would like to highlight or summarize is that the ideal treatment of a spinal vascular malformation is the one that permanently obliterates either the nidus of the AVM or the fistula without compromising the spinal cord blood supply or damaging the spinal cord. And whether this can be accomplished safely and by which means depends largely on the type of the spinal vascular malformation. So whether it's going to be surgery or embolization, this very much varies based on the actual case itself. And then the outcome after the treatment depends not only on the type and location of the lesion, but also on the patient's preoperative neurological function. So as I've spoken here earlier about this patient, now is like 8 or 9 months after his diagnosis. Other patients have been years going undiagnosed, so they might not regain functions as much as we hope. And then I would say that the optimal outcome depends on early diagnosis of these patients and interventions. But as we mentioned and alluded to, sometimes it's very difficult to diagnose those patients earlier on. So in conclusion, I want to say that to establish the correct diagnosis and to perform successful treatments in cases of arteriography occult AVFs, the treatment strategy lies mostly on understanding the clinical presentation of the patient, the epidemiology, the anatomy, and the pathophysiology of the spinal and dural AV fistulas, understanding why the venous hypertension causes that, why the arterialization causes that. Something we did not allude to much was the Steele phenomena that some neurosurgeons and neurologists refer to when it comes to those vascular malformations. I would like to thank the spine team, who I've learned from a lot during my last 4 month, and my chiefs and the vascular team for allowing me to visit their angio suite and see those cases lively. I'm happy to take any questions and comments.
Great job, Adam. It really a tour de force in looking all at all of that. So this particular case, like you said, was negative angio, positive MRA, and it's not that uncommon. I think we have at least, I can think of 6 or 7 cases, and you nicely talked about how come, why is that? And a lot of it has to do with atherosclerotic disease, occasionally due to sort of aberrant sources of the fistula. But my question to you is, when our angiographers come out of doing a spinal angio, particularly the residents, they look exhausted, and it sometimes takes them 2, 3, 4 hours to do it. There are tons and tons and tons of radiation involved. And so, we rarely have a positive angio and a negative MRA. So MRA seems to be more sensitive in picking this up. So I just wonder whether that can't be used in all cases, to sort of help delineate where their focus should be. And then again, understand that there's going to be a certain percentage of cases that are going to come back negative, and sort of make a more fine-tuned diagnostic spinal angio. What are your thoughts, and what are our thoughts of our vascular colleagues?
Yes. So looking at the literature, I wanted to also understand that. So, for example, our colleagues here in the radiology department, they looked at how the MRA would actually find those, they looked at MRIs and then MRAs and people that had MRAs and MRIs, and they try to see what's the specificity and sensitivity of that. And that reached up to 100% when they had the MRAs done. That being said, the angios are still thought as a gold standard because it helps also understand the anatomy of the spinal cord. When it helps in some cases to understand how to approach the case. But I'm sure I'm gonna defer to you if you think that the angio helps in the case in going in operating, or not as much if you only had the MRA. I think that was the point that was debated about how like this selective diagnostic angio is still needed till this day, although the MRAs are reaching now with the new sequences, as I mentioned, the twist and the 4D and all that is reaching a high specificity and sensitivity. Do you still need to have like a map of the vascular supply of the at that point or not?
Yeah, no, there's no doubt that spinal angio is, the gold standard and is very helpful for surgical planning. It's just a question of whether the MRA can help fine tune the spinal angio so we don't, do 32 vessels and if we're not getting into that segmental, after 2 to 3 hours of trying, it's okay to give up sometimes. But again, I don't know if Dr. Marcos or Stark or Peterson have any comments.
Hey, Alan, can you guys hear me?
Yeah.
I was speaking to Adnan Siddiqui from the Buffalo group, obviously a very accomplished endovascular. They have stopped doing, he tells me, spinal angiograms with the excellent MR protocol that they have to at least diagnose an AVM. Now, of course, if they need to target it, then they do the angio selectively. And they have stopped doing these, as you said, multi-hour spinal angiograms. So it's an interesting shift since the early days of doing it. But I don't know if Eric and Bobby are online to comment as well, but that was one comment. The second comment to Adam. Adam, in your readings, have you come across what would you say is different in the surgical resection of spinal cord AVMs versus brain AVMs? There is a very specific lucky difference in what looks to be very complex spinal cord AVM that you can get away with surgically that you cannot get away with brain AVMs. You know what I'm referring to and who described this?
I'm not quite sure. No, who are you referring to? But my thought is understanding that you do not, in the spinal AVMs, you do not need to resect the whole AVM. You just need to find the fistulous point, or you need to find the connections and just dissect the connections without needing to strip this whole spinal cord.
Yeah, exactly. You can actually, Spetzler's, you can amputate the entry points in these complex intramedullary ones.
Yeah.
You would never be able to do that. I'm sorry, I missed the first few minutes of your talk. I don't know if you mentioned it, but
no.
But you did. Oh, okay, all right. In brain AVMs, of course, you'll kill the patients if it's an so-called incomplete AVM resection.
Point I would make is that, the MRA technology, I'm not going to say it was developed here, but there was a lot of that initial work was done here in Miami, and it was done in part by Efrat Saraf-Levi, but Bob Quenzer and Brian Bowen, who passed away maybe, I don't know, 5 or 6 years ago, was really instrumental in helping with some of the sequences and things like that.
Yeah, I agree with you, Dr. Levy. There's a lot of papers by Dr. Bowen by himself, like as a single author, where he explains the MR angiography, and it led to my understanding a lot more about how it developed and the different sequences and why it's different than just the normal MRI. So I think that's very helpful as well for us as residents to be aware of.
Terrific. Well, if there isn't any other questions, I believe we have a Miami project speaker.
So good morning, everybody. Thank you for inviting me today. Today's my topic is the role of amygdala in processing of itch and anxiety. So you may have a question why we study itch. So I think most of you have experience to be bitten by mosquito, and then that time most of you probably feel the itchy, and then that type of the itchy is easy to deal. Like you know, after a few hours it's gone, or like by treating with the OTC drug, then that's easy to deal with it. But what we consider is the chronic itch. Our society is defined the chronic itch, which lasts more than 6 weeks. And then one of the epidemiology studies showed that 1/4 of the people experience the chronic itch in their lifetime. Actually, chronic itch occurs like from the different condition. For example, dermatologic condition, or like a systemic disease, or a neuropathic condition, or a psychogenic condition. And then estimated cost of the chronic itch is about like more than $90 billion per year in the US. And then itch is significantly affect the patient's quality of life. One of the studies showed that the prevalence of the suicidal ideation is about 21% with itchy, and this number is similar to the chronic pain. And then this is actually the most extreme case of the chronic itch. The woman has the post-herpetic itch on her head, and then since it was itchy, she scratched, and then she keeps scratch, and then eventually her scalp is defected, and then her brain is exposed like this. So from this example, like you know how much itch has an impact on the patient's quality of life. So then currently the most of the type of the chronic itch are the resistant to the antihistamine. Only the hives can be treated with the antihistamine. So there's a compelling need to understand itch mechanisms in order to develop more effective mechanism-based treatment. So under the chronic itch condition, there is the itch scratch cycle, like especially in the atopic dermatitis patient. When they feel the itchy, they scratch, and then scratch causes skin damage, and then that causes like inflammation, and then inflammation actually enhance the itch, and then enhanced itch again induce the scratching, and then there's the itch scratch cycle. In addition to the itch scratch cycle, there is the itch anxiety cycle too. So chronic itch patients often complain about the anxiety, and then experimentally the induced stress or anxiety can enhance the itch in any condition. So there is the itch anxiety cycle too. So we want to stop this cycle, but we don't know how this cycle goes. Then to understand that cycle, we target the amygdala. So there are several reasons. So the amygdala is known as the central component which processes the emotional component of the pain. And then another fact is the amygdala is the key brain region which is responsible for the generating the anxiety. Also, one of the most important thing is that the human MRI study shows that amygdala was activated during the itch stimuli. So for those reasons, we target the amygdala to understand how brain processes the itch and anxiety. So we used actually the mouse model, and then some of you may think why we use the mice. Actually, the mice is the validated model for studying itch. Here in this table, I show the three the itch-inducing chemical: histamine, compound 4880, which is the mast cell the degranulator, and then serotonin. This is another inflammatory mediator. And then all of those three chemicals can induce the itchy in human. And then when we inject those chemicals to the mouse back intradermally, mouse show the scratching using the hind paw. The same chemical, for example, histamine, when we inject the histamine to the rat back, they don't show the scratching. Also, like compound 4080, rat doesn't show the scratching. And the serotonin, only serotonin can evoke the scratching in the rat. And dog, also dog is not at least good the acute itch experimental model. For example, when we inject histamine, some dogs shows the scratching, but others doesn't. And then if we try to repeat it, other dogs show the scratching, then some doesn't scratch. So it's not the good experimental model for at least for the acute itch. And then another important reason is the lot of resource of the transgenic animals. So first, we try to validate amygdala neurons mediate itch and anxiety in mice. So first, we test whether prurigen, like itch-inducing chemical, can elicit the anxiety-like behaviors in mice. And then second, we test whether the itch-inducing chemical can excite the amygdala neurons using the in vivo single-unit recording. And then third, we test whether the optogenic activation of the itch-responsive amygdala neurons can modulate itch and anxiety-like behavior. So to measure the anxiety in mice, we use the three different the behavior tests, but today I will show you the one of them. It's called elevated plasmates. So elevated plasmates consists the 4 arms, and the 2 arms has the wall, and then another 2 arms doesn't have a wall. So the wall has a wall, the arm has a wall, we call the closed arm, and then arm doesn't have a wall, we call the open arm. And then with the mice with the low anxiety, like naive mice, they can spend they can move to the everywhere, like in the closed arm, also open arms. But mice with the high anxiety, they only can spend in the closed arm, not open arm. So by measuring the time in open arms, we can evaluate the anxiety in mice. For example, if the mice spend short time in the open arm, so that means mice has anxiety. Then using the elevated plasmids, we try to evaluate the anxiety level after the getting the itch. So first we inject the itch-inducing chemical to mouse back, and then we place the mice in the elevated plasmids, and then we record the 10 minutes, and then we measured how much time mouse spend in the open arm. So this left graph shows the results from the after histamine injection. And then as you can see here, after histamine injection, we can see the significant reduction in time spent in the open arm. The green graph shows the after chloroquine injection. Chloroquine is the anti-malarial drug, but the side effect is known as the itchy. And then actually, by injecting the chloroquine, we can see the scratching behavior in mice. And then here, we inject the chloroquine, and then we place the mice in the elevated plasmids. Now, like histamine, we can see a significant reduction in the open arm times too. Same for the serotonin, we can see the significant reduction in the open arm time. So those results indicate that each stimuli can induce the anxiety-like behavior. And then we use the capsaicin as a positive control, and then we can see the significant reduction in the open arm too. And then next, we checked whether each chemical can actually activate amygdala neurons in mice. So we used the force staining to test this. So force is the neural activation marker. So by counting the number of the false positive cells, we can tell that those regions are actually activated or not. So from the left, this is the amygdala neurons after the PBS injection, and then small green dot. Each small green dot indicates the false positive neurons. And then after the PBS injection, there are some the green dots. And then next one is the after the histamine injection. You see that much more robust the C4 expression in the amygdala. And then similar for the chloroquine, you see more force, and the serotonin also has a lot of force in the amygdala. Then next, we actually record the neuronal activity of the amygdala after each chemical injection. To do that, we use the single unit recording from the amygdala in vivo anesthetized mice. So first, we anesthetize the mice, and then we drill the mouse head, and then make a hole, and then we insert the electrode in the amygdala. And then we inject a small amount of the histamine to the mouse foot, and then try to look for the firing unit. And then once we found the firing unit, we stop moving the electrode. We stay the electrode there, and then we inject a large amount of histamine, or we start other stimulation. This slide actually shows one of the examples of the histamine responsive amygdala neurons. So the y-axis shows the impulse per second frequency So if this number increase, that means like the neuron shows more the firing. So this the amygdala red dot shows that where we recording from. So it's actually this unit was recorded from in the CEA, central amygdala. And then this location was determined by the lesion evoked induced by the electric current. Okay, so this unit shows the increase in the firing as after histamine injection, as you can see here, and then peaked it's immediately activated, and then peak was about like more than 5 hertz. And then this activity ceased about like 25 minutes after the injection. And then same unit, we test the brush. We apply the brush to the foot. There's no activation, no increase in the firing. This is the pinch stimuli. We apply the pinch to the foot, and then you can see the increase in the firing by pinching the foot. And then with the PBSID injection, we don't see any increase in the firing. With the chloroquine injection, we see slightly increase in the firing. And then with the serotonin injection, we see again the small slight increase in the firing. And then PBS twin is the vehicle for the capsaicin. We don't see any increase in the firing. In this unit, capsaicin didn't increase the firing. Then here we show the average time course of the histamine response, also chloroquine response and serotonin response at the top. And then at the bottom, we show the time course for the scratching behavior after each chemical injection. So let's see the left top corner. This is the histamine-induced firing. This, as you can see here, you can see the increase in the firing after the histamine injection, and then the peak comes, about immediately, and then the activity goes away within the 25 minutes. And then chloroquine is similar. Firing peaked immediately, and then activity goes within 25 minutes. And then serotonin is a bit different. So serotonin increased the firing immediately, but the firing activity goes away within 15 minutes. It's a little bit short response. Then here we show the behavior, scratching behavior time course. So it's actually very similar to the firing pattern. The scratching peaked at the first 5 or 10 minutes, and then goes away within 25 to 30 minutes. And then chloroquine is also similar, peak comes within 5 or 10 minutes, and then scratching goes away about 30 minutes after. And then in the case of serotonin scratch is done within the 15 minutes. So very similar time course. And then one of the things I'm surprised is the firing time course. So my the postdoctoral work was the spinal cord neuron unit recording after each chemical injection. But in that case, most of the unit that shows the much shorter the activity, even after the histamine or chloroquine injection. But in the case of the amygdala, we can see the much longer the response. So we originally thought the reason why we don't get the longer response is due to the anesthesia, but in the case of the amygdala, we anesthetize mice also. So yeah, amygdala seems to be very interesting target for me. And then here, we check the response property of the protein responsive amygdala neurons. As I mentioned you briefly at the beginning, for this electrophysiology recording, we inject the small amount of the histamine to identify the single unit. So all of the neurons respond to the histamine. And then about 1/3 of the amygdala neurons respond to the histamine only. And then about 1/4 of the neurons responds to the all the each chemical we tested in this study. And then the rest of neurons respond to the histamine and serotonin or chloroquine. And then the right pie chart shows whether each responsive neurons also respond to the painful stimuli. So we use the pinch to induce the mechanical pain, and then we also use the capsaicin to evoke the chemical pain. So about 50% of them responds to the pinch and the capsaicin, and then 39% of them respond to the itch and capsaicin or pinch. And interestingly, the 15% of the amygdala neurons only responds to the itch stimuli, but not the painful stimuli. So now, next we try to manipulate the itch responsive amygdala neurons. To do that, we use the targeted recombination in active populations that is called the TRAPS system. To use the TRAP system, we use the force Curie ERT2 AI14 mice. So in this mice, the Curie ERT2 is under the force promoter. And then the TD tomato is after the LOXP stop codon site. So then, since Curie ERT2 is under the force promoter, once the neuron is activated, Curie ERT2 is translated. And then translated Curie ERT2 released into the cytoplasm. And then Curie ERT2 need to get into the nucleus to work as the recombinase. Then to get into the nucleus, Curie ERT2 require the tamoxifen. Here we use the 4-hydroxytamoxifen. This is the metabolite of the tamoxifen. So the Curie ERT2 only can get into the nucleus when the 4-hydroxytamoxifen exists. So that's the reason, like the time frame, like time window when the 4-hydroxytamoxifen exists, only Curie can get into the nucleus. In the actual experiment, we inject the 4-hydroxytamoxifen, and then we inject the histamine as an itch stimuli. And then since 4-hydroxytamoxifen is metabolized within like 12 hours, only that 12 hours, in that 12 hours, only the cells activated, but that time window is only has a Curie recombinase in the nucleus. So here we show the after PBS injection, after PBS and TD PBS and 4-hydroxytamoxifene injection, we see some red signal. This is due to the TD tomato expression. So this means in these red cells, we have a Curie recombinase in the nucleus. And then the right image shows that after the histamine injection, you see more red signal TD tomatoes. So you can see that the more cells are actually trapped by this system. Since now the histamine responsive neurons has the Curie recombinase, so we use that advantage. So we deliver the Curie dependent Chronos GFP into the amygdala. So Chronos is the light sensitive channel, actually blue light sensitive channel, blue or green light sensitive channel, and then GFP is the fluorescence. And then we deliver this gene using the adeno-associated virus. So we directly inject this AAV into the CEA, and then we implant the optic fiber over the amygdala. So here you see the TD tomato positive cell. Those are the histamine responsive amygdala neurons. And then as you can see here, most of them has a GFP. And then this GFP means like having the light sensitive channel like Chronos. So using that mice, we did the in vivo the electrophysiology, and then we record from the amygdala neurons, and we deliver the blue light. Since now the histamine responsive amygdala neurons has the light sensitive channel, so by delivering the blue light, we can activate the amygdala neurons. So that's actually happened with our the in vivo electrophysiology recording. You can see here that by turning on the blue light, we can see the increasing the firing. But the light sensitive channel is specific for the blue or green light. By delivering the red light, we don't see the increase in the firing. So this is kind of like proof of the concept of our the method. And then using that trapped mice, we test we run the anxiety test. So we place the mice on the elevated plasmids, and then first we use the PBS trapped mice. This is the mice received the PBS during the after the tamoxifen injection. So this should be the negative control mice. And then we place these mice on the elevated plasmids, and then we record 9 minutes. And then first 3 minutes, we didn't deliver the light, but the second 3 minutes, in some case, we deliver the light. And then last 3 minutes, we didn't deliver the light. So then the mice, in the case the mice didn't receive the light, we see that like first 3 minutes, about 60 seconds, the open arm time, and then next 3 minutes, we see the slight reduction, about 40 seconds. And then last 3 minutes, we only see the about 20 seconds time spent in the open arm. And then when we deliver the light, I mean, the first 3 minutes without light, it's very similar. And then the second 3 minutes, we deliver the light, the numbers are very similar. And then at the third 3 minute period, it's a very similar number. Then right graph shows the when we use the histamine trapped mice. So these mice has the light sensitive channel in the histamine responsive amygdala neurons. And then when we didn't deliver the blue light, It's like first 3 minutes is about 60 and then goes down 30 and then third 3 minutes period, they only show the 20 seconds. And then when we deliver the blue light, first 3 minutes period without light, the number is very similar, but second 3 minutes period, we deliver the blue light. Now we see the almost, almost zero of time spent in the open time. And then there's a significant difference between the light off versus light on condition. So from this result, we conclude that by activating the histamine responsive amygdala neurons, we can increase the anxiety-like behavior. And then next, we use we test the itch behavior using the trapped mice. Here's the sample video. So this mouse has the wire. This is connected to the light source, and then we implant the optic fiber on the mouse head. And then I start the movie. Now you see the blue light is blinding, and the mouse shows the scratching. And then at the end, mice also shows another scratching. So we count the number of the scratch bolt, like I show, like that kind of behavior. And then first we use the PBS trapped mice. This is the negative control mice, and then we inject the histamine. And the histamine evoked about 40 scratching in 30 minutes. And then next we deliver the blue light and then also inject the histamine. But the number of the scratch both were very similar in the condition without light. And then next we use the histamine trapped mice. Again, this mice has the light sensitive channel in the histamine responsive amygdala neurons. So by delivering the blue light in these mice, we can activate the histamine responsive amygdala neurons. And then here, just injecting the histamine without light, we see about 50 scratching. And then with blue light, now we can see the enhancement of the histamine evoked scratching. Then next we use another itch-inducing chemical, chloroquine. First, we use the PBS trapped mice. By injecting the chloroquine, we see about 100 scratching, and then with the blue light, the number wasn't changed significantly. And then next, we use the histamine trapped mice. Chloroquine induced about 100 scratching, and then by delivering the blue light, in addition to chloroquine, now we see the enhancement of the scratching induced by chloroquine. So here's the summary. So we can induce the anxiety-like behavior after the itch-inducing chemical injection in mice. And then we can confirm that the subset of the amygdala neurons show increased firing after the itch-inducing chemical injection. And then the firing time course is very similar to the that of the scratching behavior. And then importantly, the direct activation of the itch-responsive amygdala neurons can increase the scratching behavior and the anxiety-like behavior. So yeah, we can validate that the subset of the amygdala neurons has an important role in the behavior response to the itch and the anxiety-like behavior. So, so since we have the good model, we want to see which kind of molecules actually involved in this processing. So to find out it, first we did the search for the candidates gene that may signal or modulate itch in the amygdala. So to do that, we used the RM Brain Atlas, and then we used the human brain database, and then we did we ran the differential search, and then we listed the gene which preferentially expressed in the amygdala in the human. And then after that, we checked any of them are actually expressed in the mouse center CEA, especially in the CEA center amygdala. Then we identify the few of the interesting target. So one of them is actually the OPLM OPLM. So this is still ongoing study, but I think it may be, I think it's very interesting for you guys to. So here I show the data results from the RNA-scope imaging. So we stain the OPLM messenger RNA, and then as you can see here, OPLM messenger RNA is mainly expressed in the CEA central amygdala. And then here I want to explain why the OPLM like MOR is a very interesting target for us. So I think as many of you knows, the MR agonist is the super analgesic drug like morphine. But one of the side effects is the itchy. So after like a neuraxial opioid administration, about 83% of the postpartum patients and 69% of the non-pregnant patients exhibit like itchy. Also, of course, after the pregnant, in the pregnant woman, about 60 to 100% of the them experiencing the itchy after the neuraxial opioid injection. And then, interestingly, the current study is actually focusing on the mechanisms of the morphine-evoked itch in the spinal cord, only in the spinal cord, not other brain, not other region. But here, there's some other discrepancy. I mean, the onset of the pruritus, like itchy, occur like within the 30 minutes or like 3 hours after the neuraxial administration of the morphine. So that means like what if itch occurs within the spinal cord? Why this delays happen? And then another interesting thing is the main part, typical part of the itchy is after the morphine injection is like nose or like upper part of the face. So what that means is here I want to show some interesting experiment result. So this is the data from the non-human primate, and they inject the intracisternal. They inject the morphine intracisternally and intracecally, and then after the intracecal, the intracecal injection, it's showing the blue triangle. The scratching to the body occurs like immediately and then increases slowly. But scratching to the face has like a delayed onset, like maybe like after 20-30 minutes later, they start showing the scratching to the face. But when they inject the morphine directly to the brain, the intracisternally, they can see the immediate head scratching. They observe the immediate head scratching. So this suggests the target of the morphine could be the brain too. Some of the brain region too. And then that facial scratching is actually induced in the mice too. So this time course shows the facial scratching after the intracisternal injection of the morphine. And then this shows the sum of the scratch bout. And then you can see the saline injection only induces like 10, but after morphine injection, you see the over 60 times of the facial scratching. So yes, in the mice, we can see we also observe the facial scratching immediately after injection of the intracisternal morphine. And then the right image shows the potential brain nuclei of which neurons respond to the intracisternal injection. So in the one of them is actually amygdala. So why not injecting the MOR agonist into the amygdala to see whether that can induce the itch behavior? This is what we did. So we implant the guide cannula in the mouse, and then we insert the needle directly to the amygdala, and then inject the Damgo, which is the MOR agonist, directly to the amygdala, and then we record the mouse behavior. Then, as you can see here in the left graph, you see the significant increase in the scratching after Damgo injection. And then in the middle, we test whether the inhibiting the MOR can reduce the scratching behavior. Then we inject the naltrexone. This is the MOR antagonist. Yes, it has some affinity to the other receptor too, but we directly inject the naltrexone into the amygdala, and then we inject the chloroquine, one of the itch-inducing chemical. Then now we see the significant reduction of the chloroquine box scratching by naltrexone pretreatment. Similarly, when we inject histamine, we see the reduction of the scratching after the naltrexone treatment. And then this graph is just showing the amygdala is actually one of the target site for the analgesic action of the morphine. So this is actually they inject the formalin, and also inject they inject the formalin to the paw to induce the pain, and then they inject the morphine to reduce the pain, and then they are showing the analgesic effect, how much analgesic effect there by the morphine. And then here they are making the lesion in the amygdala, in the actual central amygdala. They can inhibit the analgesic effect, the morphine-induced analgesic effect. So this is just again just showing the one of the result, which shows the amygdala, central amygdala is the target for the analgesic effect of the morphine. So yeah, what we found is the intraamygdala injection of MOR agonist elicit the scratching. Since considering that the MOR is predominantly coupled to the GI, So that means like when the MORs bind to the receptor, that usually inhibit the neuronal activity. So if that's the case, the most likely the this inhibition of each pathway is causing the itch in the amygdala. So another important fact is the central amygdala is consisted by the GABAergic neurons. So most of them are actually the inhibitory interneurons. And then in the end, like this is actually like a very interesting target for us because we still don't know how the brain the process like distinguish between itch and pain. So as you see the amygdala apparently activating the amygdala, causing the analgesic effect, and then instead on the other hand, like MR activation in the amygdala causing the itchy. So seems like this is the key location for the brain to distinguish between itch and pain. Okay, then since as I mentioned you from the MR result, we expect that there should be some the itch inhibitory circuit in the amygdala to for the morphine to disinhibit itch pathway. So we actually find one of them that is the PDYN positive population. So here we show the location of the PDYN, the messenger RNA. They are mainly expressed in the CA. And then we use the PDY, we prepare the PDYN curi mice to target the PDYN positive neurons, and then we inject the AAV, which contains the curi dependent crimson R TD tomato. So crimson R is the red light sensitive channel, and the TD tomato is red fluorescence. And then we implant the optic fiber just above the amygdala, and then we deliver the red light. And then this the staining image shows the TD tomato expression. So we confirm that the TD tomato is mainly expressed in the CEA after the AAV injection. So now the PDYN positive neurons having the crimson R, that's light sensitive channel. And then we use the itch test. Then in this case, we use the histamine and chloroquine to induce the itch. By injecting the histamine, we can induce the scratching, and then this scratching was inhibited by delivering the red light to the amygdala by activating the PDYN positive neurons. And then similarly, the chloroquine evoked scratching was also inhibited by the red light. And then next we test the pain test. We use the Von Frey test for mechanical pain. We also use the Hargreaves test for the feet pain. So in the case of the mechanical pain, we don't see the significant change of the mechanical pain threshold by delivering the red light. We deliver the red light in the middle. And then in the case of the heat pain, by delivering the red light, we can see the increasing in the pole withdrawal latency. So that means the heat pain threshold is increased. And then we also run the elevated plasmid with these mice. So you can see here, by delivering the red light, we can see the decrease in the open arm time. So that means the activation of the PDYN positive neurons, inducing the anxiety-like behavior. Then the next we want to possible target of the PD-1 and the amygdala neurons. Let me briefly introduce what we know so far about the descending pathway for each. So there's actually two known descending pathway for each. One is in the descending facilitatory pathway. This is starting from the PAG, goes to the RBM, and then go to the spinal cord. This is the serotonergic pathway. And then another one is the descending inhibitory pathway. It starts from the PAG, goes to the LC, Lucas corneas, and then it goes to the spinal cord. This is the noradrenergic system, neurons. And then very recent study, last 3 years, there are unique the unique subset of the amygdala neurons are reported. So those are basically the projecting to the PBN from the CA. And then all those subset of the neurons actually inhibiting the pain. So we try to, we thought maybe this similar pathway might be involved in our the PD-1 positive neuron. So to test that, we used the activation of the PD-1 positive amygdala pathway. Like instead of the implanting the optic fiber above the amygdala, now we implant the optic fiber above the PBN. So that way, now we can only activate the amygdala neurons, which project to the PBN. And then we check the PD-1 positive neurons terminals are expressed in the PBN, like as you can see here, those red. So then we did a similar study, and then the results are basically mostly similar. So by activating the PBN projection, now we can inhibit the histamine box scratching, chloroquine box scratching. And then the form 5 test is a little bit different, but now we can increase the mechanical pain threshold. And then for the Hagley test, we can increase in the heat pain threshold. And then for the elevated plasmates, we don't see any big difference. And then to further confirm that whether the PBN projection actually inhibit the itchy response, we used the CFOS study. We ran the CFOS study. So we inject the chloroquine and then to the mouse back, and then in that case, like we didn't deliver the light. So you see a lot of false positive neurons, like green dot here. And when we deliver the red light with the chloroquine injection, now we don't see that much of the green dot. So here's the average data with previous injection. There's not so many false positive neurons, but after injecting the chloroquine, you see the increasing the false positive neurons, and then you can decrease that number by activating the PBN projection neurons. So here's the summary. So by activating the amygdala PD-1 positive amygdala neurons, we can inhibit the itchy and the heat pain. And in the case of mechanical pain, it wasn't big difference. And then it caused the anxiety a little bit. And then by activating the PBN terminals, now we see the similar result. It can be inhibited by the stimulation. Also, heat pain is also inhibited. Mechanical pain is inhibited in this case, and anxiety didn't change. So since the PD-1 positive amygdala parabrachial nucleus projection neurons inhibit itch, so given that itch responsive amygdala neurons increase itchy, so the subset of the itch responsive amygdala neurons may inhibit the PDYN positive amygdala parabrachial nucleus projection neurons. And second, PDYN amygdala parabrachial nucleus projection neurons modulate both itch and pain. A subset of the PDYN positive amygdala parabrachial nucleus projection neurons might specifically modulate the itch. So in the bottom shows the schematic diagram for the hypothetical amygdala circuits for itch. So the itch stimuli activate the subset of the amygdala neurons, and then that can release the maybe like endomorphins, such as some MOR agonists, and then that actually inhibit the PDYN positive subset of the PDYN positive the amygdala neurons, and then that actually project to the PBN and to inhibit the itch. So yes, this is it. So thank you for the acknowledgement. So this is it. So thank you for listening. If you have any questions, just let me know.
Well, thank you, Dr. Akiyama. That was really very interesting.
Thank you.